friends. Good evening, friends, and welcome back. Today, as I said, you will be discussing about the COVID-19 ICU management. Especially, this lecture is meant for the primary healthcare physician in a very simplified approach. All those doctors who are treating the patient in the ICU, especially the physician and primary healthcare physician, will be targeting those. And I have made my approach quite simpler, practicable, and comprehensible. So let's start. Now, your patient gets admitted in the COVID ICU and the patient is hypoxic. Now we have divided into three categories: the patient requiring a low flow oxygen delivery system, a patient requiring a high flow oxygen delivery system, and third is the patient gone into the ARDS. As far as the ARDS is concerned, we'll be discussing about the ARDS and the management, general principles of the management in my next lecture. Today we are going to cover the basic principles and the management of hypoxic patients with COVID-19 infection. So to begin with, there are some subsets of patients who require a very low flow oxygen. That is to say, there are the group of patients who requires an oxygen requirement less than 6 liters on simple nasal bronchs. So we will categorize these patients as a low flow oxygen requiring patients who require it. The first thing you should always remember is ask the patient to have a prone position as much as possible. I know it is practically difficult and uncomfortable for the patients to remain prone, but in 24 hours, as much as possible, the best is around 6 to 8 hours. If they remain prone, they can avoid or prevent from getting intubated. So there are a lot of data to support it. So we call it as a self-prone or awake prone position. The benefits a lot. We can prevent the intubation. Secondly, if the patient is conscious and able to breathe normally, encourage this patient to have a deep breathing exercise. That's what I have demonstrated in my previous lectures. So deep breathing exercise. And what should be the target of oxygen? Please understand, when you're giving a low flow oxygen, remember the lowest FiO2 to keep the SpO2 more than 90%. Better if you can maintain it over 94% as per WHO. So the lowest concentration of the oxygen to maintain SpO2 over 90% should be our target. Please understand this fact, very importantly. Dear friends, remember there is a caveat that very important. At times the pulse oximeter overestimates the hypoxia, arterial oxygen saturation. That is to say, in dark-skinned individuals, the patient may be hypoxic, but the pulse oximeter may show the saturation over and above 95%. Always remember the dictum. The gold standard is always have a clinical eye, a clinical judgment. Look at the patient, whether the patient is breathless at rest. Look at the respiratory rate more than 30 breaths per minute. Look for the cyanosis. Patient is having a severe dyspnea. That means even at rest, the patient is unable to speak. He has to pause while talking. So these all features indicate the severe breathlessness. So don't get carried away just by pulse oximetry. So this is very important. The target is to keep the lowest amount of oxygen, the FiO2, to keep the SpO2 more than 90%, and the clinical judgment is required. Needless to say, friends, that often you require a supportive treatment. That means these patients who are admitted in the ICU, kindly look, the patient should be well hydrated because there is often anorexia, nausea, vomiting, so the patient is dehydrated. So ensure a good nutrition, deep vein thrombosis prophylaxis, stress ulcer prophylaxis, and infection control and treatment is very important. Please understand that all these procedures are at the high risk of aerosolization because these are the thing which can contaminate the environment. So one should take all those precautions. We'll not discuss in this talk today. So in short, now there are some subsets of patients, despite on the low flow oxygen, they may require a high flow oxygen delivery system. So those patients who require more than 6 liters of the oxygen, say more than 10 liters to maintain the saturation, we will categorize them the patients on a high flow oxygen system. So these patients are having two modalities of treatment with us. One is a high flow nasal cannula and non-invasive ventilators. We have two modalities with us. Friends, as per the latest data what we have today, I would strongly recommend, or the data strongly recommends, HFNC as the first line treatment. We have learned this from our experience in Middle East respiratory syndrome in patients with hypoxic respiratory failure. The HFNC was much superior than non-invasive ventilation in management of hypoxic respiratory failure patients. So the first line should be HFNC and the second line should be NIV. Definitely, these patients may require a transition between HNFC and non-invasive ventilator, especially while eating and sleeping, so you can shift accordingly. So in this, a device has been attached and a high flow, high volume oxygen has been given to the patient. So this should be the first line. Now we will just talk about the non-invasive ventilations in a patient with SARS corona infection. What should be the prerequisite before you start a non-invasive ventilation for this type of patient? The first and foremost, the patient should be cooperative. The patient should be able to protect their airways. The patient should be able to breathe spontaneously, and patient should be able to cough effectively. So these should be the prerequisite condition for the patients whom you are considering to start non-invasive ventilation. So the benefit, a lot of data are there to support that non-invasive ventilators is much more superior and highly efficacious in preventing the subsequent intubation in the patients with acute exacerbation of COPD and acute cardiogenic pulmonary edema. So once you put your patient on non-invasive ventilations, after 1 or 2 hours, get an arterial blood gases analysis, see if it is okay, then you can repeat it every day. So by and large, you can keep your patients for 8 to 10 days depending upon the clinical response. So let's come back to the non-invasive ventilation. Now, in non-invasive ventilations, we have two modalities. One is CPAP and other is a bilevel. CPAP stands for continuous positive airway pressure. Especially those patients with hypoxic respiratory failure whom you put the non-invasive modality, the CPAP has often been initiated. Okay, so ideally the initial pressure setting is around 5 to 10 centimeters of water you can help. The benefit of CPAP is it helps to recruit the collapsed alveoli and it enhances the clearance of alveolar fluid. Example, in the cases of cardiogenic pulmonary edema, patients with pulmonary atelectasis, the CPAP is often advocated. Second, we have a bilevel. They are also known as BPAP. So, bilevel positive airway pressure ventilation. The indications for the bilevel or BPAP is hypercapnic respiratory failure. CPAP is for the hypoxic respiratory failure, and BiPAP usually we use in the patients with acute exacerbation of COPD, especially the hypercapnic respiratory failure. Or in certain cases when we are trying to wean off the patient from mechanical ventilators, we use the bilevel positive airway pressure ventilation. Now these BiPAP usually have the two modalities. One is IPAP, that is inspiratory positive airway pressure, and other is expiratory EPAP. And in between is a delta PAP. Delta PAP is the difference between the IPAP and the EPAP, and it correlates with the tidal volume. So it has two modalities. Inspiratory pressure. The inspiratory pressure is sufficient to keep the alveoli open, patent, and the expiratory pressure is there to prevent the alveoli from collapsing during the time of expiration. So inspiratory pressure is usually adjusted to around 8 to 12 centimeters of water. It can be increased up to the 20 centimeters, but be careful that the moment you try to increase the IPAP values, you may increase the tidal volume. Wherein in the case of EPAP, it is usually kept between 3 to 5 centimeters of water. It can be increased up to 10 centimeters, but remember, the moment you try to increase the EPAP, there's a decrease in the tidal volume. So you have to have a clinical judgment when you're just trying to, adjust between these two modalities of BiPAP. Now, in the initial setting, when you put your patient on bilevel ventilation, non-invasive, and the patient is having a hypercapnic respiratory failure or acute exacerbation of COPD with the SARS corona infection, the initial setting is you have to keep the respiratory rate around 8 to 12 beats per minute. In ST setting, what is ST stands for? Spontaneous triggered by the patient's breath, and other is a time occurring at a set frequency. So ST mode is a pre-value, means the patient's it is a breath trigger, and the time is occurring at the set frequency. Now we have set the frequency to 8 to 12 beats per minute. So this is the initial setting, you can change it. And there are certain subsets of patients who are not able to tolerate the BiPAP because see, it is a tight fitting mask over the face, airtight, or you can close the nose. But at times many of the patients are not able to tolerate the BiPAP. So in those patients you have some other modalities like PSV, we call it as a pressure support ventilation, and other is a NAVA, which stands for neurally adjusted ventilatory assist, and last but not the least is again CPAP. Yes, definitely, as we have discussed, the CPAP we use in hypoxic respiratory failure, but there are some subsets of patients with hypercapnic respiratory failure who are not able to tolerate bilevel. In those patients you can use CPAP. Despite all this, friends, in patients with corona infection, the patient succumbs and the patient does not respond, and the time comes the patient has to be intubated and put on mechanical ventilators. The whole purpose of this is to prevent the intubation, but despite all this effort, the patient requires intubation. So what are those criteria? Please understand, the first thing is the patient is deteriorating despite the patient on these modalities of breathing. There's a fall in SpO2, calls for then intubation. The patient is fatigued, worsening of mental status, and rise in CO2 level, or what we can call it as a progressive hypercapnia. Apart from it, very important, increase in FiO2 more than 0.6, that is around 60 liters, and multi-organ failure, hemodynamic instability. These are all indications that without further delay you should put your patient on invasive mechanical ventilations. Patient requires intubations. Please understand, there is no cutoff threshold, but it is often believed that any FiO2 more than 0.7 is injurious, toxic to the lung. So these are the indication. In my next talk, I'll be talking once the patient goes in ARDS, how can you manage this patient? So let us try to sum it up what we have spoken right now. Patient with the COVID-19, the drugs we have already discussed in the previous talk. In this talk, the patient requiring a low flow of oxygen. The minimum amount of oxygen required, FiO2, to maintain the SpO2 over and above 90. If it fails, keep the patient on high flow oxygen. High flow oxygen we have better, we must immediately go for first line is HFNC. These are the cases where you can start. Apart from HFNC, we have non-invasive ventilator as a second line, and we have two modalities, CPAP and bilevel. I have given you the settings, I have given you the values, how can in which all condition you can use it. See to it in all those care, the supportive treatment about the nutrition, DVT, stress ulcer prevention, infection control and treatment has to be taken into consideration. Along with it, you should have a clinical judgment and you should assess the response to the treatment line. If all these methods fail to maintain the saturation, or there's a patient deteriorating, or the patient is getting fatigued as what we have mentioned, this call for the intubation and mechanical ventilation. So thank you very much, friends. Again, I reiterate, this is a general approach for the primary healthcare physician in a very simplified way. How can we manage these patients? As far as drug is concerned, I've already discussed in my previous talk. In my next talk, I'll be giving you a general principle, how can you manage these patients on mechanical ventilators who have gone into the ARDS. Thank you very much for your kind listening. Thank you.